So coming to the last talk of this IC. So Dr. Pandav has discussed in detail everything, but I'll be discussing early post-trap hypotony causes and its management. So success of trabeculectomy depends upon preoperative consideration, how ideal is the surgical procedure, and post-operative nurturing of the bleb. So post-operative complications occurring up to 1 month, they are taken as early complications. So most of them can be managed conservatively like this with post-operative hypotonic maculopathy. Managed conservatively, we had a good outcome. So complications in early post-operative period may be related to conjunctiva, leak at the limbus, or some vertical holding. You will find normal or low pressure with flat conjunctiva. So always look for leak at the limbus or if there is any button holding or loose conjunctival sutures. So shallow anterior chamber with hypotony with overfiltration is also seen in early post hypotony. Then if the flap is good but pressure is low, then suspect scleral flap fistula or loose sutures. Then sometime we may find conjunctival retraction with leak, and in severe cases choroidal fusion or even subchoroidal hemorrhage also. So most of these complications can be managed conservatively and monitoring the anterior chamber if it is not flat. So hypotony can be due Seidels positive and Seidel negative also. So in Seidels negative, there may be overfiltration or some problem with the suturing or flap problem. And on ultrasonography, you may find choroidals. So treatment for this is give acute-suppressant, cycloplegics, and increase the anti-inflammatory in the form of steroids. And if it unsettles, you may need to explore it also. And in Seidels positive cases, look for leak. And if you are able to detect, manage it. And if the leak is small with well-formed AC and there is no lens cornea touch, observe it or do pressure patching. Sometimes you may need contact lens, or if it all fails, then again you may have to explore and look for the other causes. And if there are large choroidals with hypotonic maculopathy or lens endothelial touch, then you have to manage it urgently. Overfiltration, shallow but formed bleb, increase the dose of steroids, form AC with viscoelastic or BSS or air. Shallow anterior chamber with lens endothelial touch, you have to intervene early. Large filtering bleb, look for loose sutures of the flap, and you can manage it initially with compression suture, but if it doesn't help, then you have to explore the bleb and look for the cause. There may be a flap fistula or sometimes cleft also. So management is put on oral and topical steroid and cycloplegics, and you can also monitor the choroidal height with serial ultrasonography. So early bleb leak due to retraction can occur sometime, and you need to resuture these conjunctival. So risk factors for overfiltering bleb are young patients, high myopic patients, and juvenile open-angle glaucoma patients. So this was a case, a one-eyed patient who presented in post-trap done elsewhere with low pressures, and we did compression suture for this patient. Ultimately, this patient settled with compression sutures only. This second case was of juvenile open-angle glaucoma. Patient had trap in both the eyes 1 week apart. So one lesson is, if the one eye bleb is not settled, wait for the other eye. So this was operated 1 week apart in both the eyes, and both the eyes had hypotony, shallow AC in both the eyes, and large diffuse bleb, and hypotonic maculopathy with disc edema. I tried the compression suture in the right eye because there was no problem with the conjunctiva, but pressure rose transiently. So in other eye, I decided to explore the flap, and I found the loose suture that was sutured again, and this settled with this only. Meanwhile, in other eye, right eye again with compression suture, I decided to explore, and what we found the fistula in the flap. So we put a scleral patch graft over it, and it settles with it. So at final follow-up, both the eyes settle. So what are the preventive measures for overfiltering flap? While making the flap, see that your thickness should be at least 50 to 70%, and sclerostomy must be well covered with conjunctival flap while suturing. Always avoid tooth forceps while handling the conjunctiva, because that is the culprit for causing buttonholing. And proper wound closure with application of the tight releasable sutures, that is pertinent. Intraoperative assessment of the aqueous drainage after putting the sutures, and judicial use of anti-metabolites, its concentration, duration, and the site of application. We usually apply little posterior to the flap. So this was a one-eyed patient who was operated for trap, came with hypotony, and because he was one-eyed, so we decided to explore the bleb. And bleb was totally fibrous, but when we do intraoperative gonioscopy, we found a cleft in the bleb. So what I did, I put a scleral patch graft over it, and it settled with this. And post-operatively, the slit was very decreased and pressure was well controlled. So management option with hypotonia, in early stages, you can use intrableb and autologous blood injections or wide diameter contact lens. Sometimes if the bleb is good, there is no problem with the conjunctiva, you can try compression sutures also. Or if there is a recence of the conjunctival wound, you can advance it and put the sutures again. Or sometimes maybe free conjunctival autografts are required. If all these fails, then you need to explore the bleb, especially if the patient is referred from other side. You are not clear what is the condition of the flap and the sutures. So sometimes you need scleral patch graft also. Rarely you may get infection in the early post-operative period, so you can manage it depending upon the stage, whether it is blebitis or blebitis with anterior chamber infection only, or if there is endophthalmitis also. So management, early bleb leaks of inadvertent buttonholing or tears or conjunctival retraction, they need suturing. Hypotony with small leak and deep anterior chamber and minimal change in visual acuity, you can manage it conservatively. Aqueous humor suppressants to slow the rate of the leakage. You can try soft bandage contact lens with antibiotics for tamponade. Also, you can use autologous blood injection or cyanoacrylated fibrin glue, but outcomes are variable. For ultrafiltration, because you can try compression suture because it is a small, short time procedure. In urgent cases with shallow AC, with visual symptom and lens endothelial touch, explore the bleb and resuture the wound with or without resuturing of the underlying scleral flap. So in conclusion, thorough history of trauma or ocular hypotensive drugs use, ocular examination for having bleb leak, gonioscopy for cyclodialysis, and status of the retina, whether there is hypotonic maculopathy. If there is no indication for surgical intervention, then you can manage this conservatively with topical and oral steroid and cycloplegics. If the pressure and AC depth return to normal, then continue these medication with